On today's episode of the podcast, I'm talking with Dr. Mike Beria, the Director of Orthobiologics at the Ohio State University Sports Medicine Center. We're going to be discussing some emerging treatments in the field of regenerative medicine and particularly platelet-rich plasma or PRP injections. We're going to discuss some of the current research around PRP injections, what it's good for, what it's not good for, and what patients can most benefit from PRP injections. I think you're going to find this episode really interesting. And if you do, please subscribe to our podcast so you get notified of our future episodes.
You're listening to the St. Louis Pain Expert Podcast with Dr. Dave Candy, St. Louis's leading expert in chronic pain relief. Dr. Candy specializes in helping women aged 40 and above to overcome chronic nagging aches and pains without medication, injections, or surgery, so they can stay active, mobile, healthy, and independent. Whether you're suffering from pain yourself or know someone who is, pain's a universal experience that affects us all, but that doesn't mean you have to suffer. Knowledge is power, and having the right information can help you or someone you love get on the road to recovery. On the St. Louis Pain Expert Podcast, Dr. Candy talks with other health experts from St. Louis and around the world to give you the information you need to recover, the peace of mind of knowing that you're not alone, and the hope that lasting relief from chronic pain is possible, and it doesn't require relying on pills, injections, or surgery in order to do so. So sit back, relax, and open your ears, mind, and heart, and let the healing begin.
Welcome to the St. Louis Pain Expert Podcast. I'm your host, Dr. Dave Candy. I have with me here today Dr. Mike Beria. Mike is an assistant professor of physical medicine and rehabilitation at the Ohio State University. He's a director of orthobiologics at the Sports Medicine Center at the Ohio State University, and also just got named a vice chair of research for the physical medicine rehabilitation department. He also serves as the team physician for several local high schools and for USA Wrestling. And his work was actually inspired after having some knee surgeries of his own while wrestling at Harvard. Now, Mike and I go way back. We actually met each other while wrestling together as kids and went to the same high school. So it's nice to catch up with you, Mike.
Yeah, awesome. It's good to see you. Yeah, I was actually thinking back to that because I can remember right when I moved from West Virginia to Cincinnati, it was the Candy family is who we first met. And I remember vividly being in that wrestling room with you when we were probably 12 years old.
Yeah, something like that. It's amazing how time flies.
Yeah.
Well, kind of getting back to more recent times, you've done some recent work that I saw actually on social media about PRP, and that's a question that a lot of my patients ask about a lot is PRP and stem cells and other types of regenerative medicine. So first of all, can you explain for people who may not be familiar what PRP or platelet-rich plasma is?
Yeah. So platelet-rich plasma is where we take the patient's own blood and we can take variable amounts of it, but it's really easy to harvest. We just take it from a simple blood draw, like if you were just getting any other blood work. And then we spin it in a centrifuge from anywhere from 5 to 30 minutes. And what that does is it's going to separate out the layers of cells, and your platelets are the smallest cell. And so they're going to separate out pretty clearly. And then once we have those, that gives us a pretty dense concentration of platelets, plus or minus some white blood cells. So that's beneficial, not because of just the platelets themselves, but the platelets have growth factors that help with tissue recovery, tissue repair, and they're anti-inflammatory. So it's a natural anti-inflammatory that we can administer for some of these degenerative conditions like arthritis, tendinitis, and like muscle strains that are just not healing. So one way to think about it is in the joint or in the tendon, we've got really bad blood flow. So that's why we get injured and these things don't recover. So you have arthritis, you lose some cartilage, it degrades, and there's no blood flow. And so it doesn't recover. Arthritis doesn't recover. It doesn't regenerate itself. Conversely, if you cut your skin, you bleed and then you heal. And you might have a little scar, but it heals. So certain tissues in our body have the ability to recover, and those tissues that recover are vascular. They have blood flow. So what we're doing is we're taking the blood, we're isolating the parts that are responsible for healing, mainly the platelets, and we are administering them where they don't exist naturally.
So what types of conditions is PRP used for besides, I think you mentioned knee arthritis or tendon problems? Are there any conditions that it's more helpful for than others?
Yeah. So there's some that it's super clear that it works for, and others where it's a little bit of an unknown. So your best three are going to be knee arthritis. There are tons of randomized controlled studies that show how beneficial it is, whether compared to steroid or compared to viscose supplement or gel injections. Platelets almost always come out ahead, and study after study has shown this. So for knee arthritis, absolutely. Many of us in the field of orthopedics and sports medicine consider it the gold standard. Tennis elbow is another big one where it's effective, and then plantar fasciitis. Those are probably the big three where there's the most data and the most clinical experience showing that it works.
Are there any conditions that you know that it's just not very effective for?
There are some that we seem to struggle with. So the shoulder is a little bit of a black box. And so it's not that it doesn't work, but because the shoulder is complex, the rotator cuff and the biceps tendon, it doesn't seem as reliable. For hip arthritis, it's effective, but it's not robust. But then some of the chronic tendon problems like hamstring tendonitis, real high up on the sits bone, Achilles tendonitis, it seems really, really difficult to get PRP to work for those. So it's not that we don't use it at all, but we just have to have a much more candid discussion saying we're using this as a means of trying to avoid surgery, because they are safe. If they are administered properly by someone with adequate training, they are safe. We've not seen, I've been doing this for 6 years now, we've not seen harm come from it, but just the data doesn't clearly support it. So we just have to have a much more, much broader discussion about what we're expecting.
Now, that's good that you mentioned the safety of it, because I think that's a question that a lot of people have. Are there any side effects of it as compared to, there's side effects to having corticosteroids repeatedly over time?
Yeah, so in our experience and the literature, PRP is very safe. So what has to be done to maintain that safety, because now we are processing it. So we're taking the blood, we are putting it in the centrifuge. So we have to make sure that our sterile precautions are perfect, so that we don't introduce any kind of contaminant. So we always make sure that happens. The other safety feature of PRP is that PRP is actually antibacterial. So that lessens the chance of getting an infection with it. Compare that to steroid, where if you're diabetic, you get the big spike in blood sugar. There's some concern about how does repeated corticosteroid use affect bone health. We don't have any of those concerns with PRP. There can be a little bit of a flare-up after the injection that can last anywhere from 2 to 7 days, where you might get more swelling, a little more pain. And in every case, I can think of, the last 6 years, when that's happened, in every case, it's gone away. We have not seen anyone who has developed a problem because of PRP. And I can tell you from my own experience. So you mentioned my knee injuries. I get PRP in my own knee every 6 to 9 months. And there's always a pretty large amount of swelling, and it's sore for about 3 days, but I'm able to work through it, and I just bike and walk, and then it goes away pretty easily.
Now, how does PRP compare to some of the other popular regenerative medicine techniques like stem cells?
Good question. So stem cells, when we first got into this field, the field is really new. So the terminology and the vocabulary is changing pretty frequently. So when we thought about stem cells, we thought about 3 main interventions. We thought about bone marrow. We know there are stem cells in there. We thought about adipose. The same is true there. And all of those come from the patient. And then umbilical cord and placental products harvested at the time of C-section. So for each of these, it's actually become clear that stem cells, though present, and some of these are not the main actor. So the number of stem cells in bone marrow is so small in comparison to the rest of the cell population that there's no way that the mesenchymal stem cells in there are the primary actors. So bone marrow is largely going to be a lot of platelets. So you'll get something very similar to PRP with a little bit more anti-inflammatory protein. And there are stem cells in there, but that's not the primary actor in terms of what's helping patients. The same is true of adipose. There are stem cells in there, but the other cells that are there include fibroblasts, which are responsible for rebuilding collagen, some cushioning effect. And so the point is, we don't really consider these stem cell therapies. And we do want to be very clear. The FDA says we can't declare these stem cell therapies. So that was like old nomenclature, old vocabulary that we used to use. But as our understanding grew and we started to appreciate how broad of a cell population there was in each of these, that it probably was not accurate for us to call it stem cells. And then the only study that is really available on current umbilical cord and placental products that was published. It was published a couple of years ago in the American Journal of Sports Medicine, and a group out of, I believe it was UC Irvine or UC Davis, I don't want to misquote them, looked at what was in the contents of these umbilical cord products, and they could not find any stem cells in there. It mainly was just the viscose supplement, which is made up of hyaluronic acid. That was the major component of all these injections. So right now, we don't really even market these or discuss these as stem cell therapies. They are biologic. They are biologically active. They're anabolic. They help to rebuild tissue and restore. But we're getting away from like the stem cell concept.
Now, there are people out there who, I've seen ads or different things for stem cells online. Can you speak to some of those?
Yeah, absolutely. So you might get mailers in your mail, or like you said, it might be on Facebook or another social media platform. And we do have a lot of concerns about these quote unquote stem cell clinics. We have seen a significant amount of harm come out of them. So typically what they're doing is they're often run by certain disciplines of medicine that don't have state privileges to do procedures. So they actually hire out the procedures to other individuals. And the product that they're using mainly are some of these umbilical cord products. And like these things, they can be very dangerous because these companies that are harvesting the umbilical cord or the placenta, they do it at the time of live birth C-section. Well, if you don't do that perfectly, there's obviously a lot going on during a C-section and the delivery. And so these products have become contaminated. So if you listen to, there was a podcast a while ago called Bad Batch, and the company was Livion. This is known. You can Google it. You can find it anywhere on the internet. That a lot of people got very sick from these stem cell clinics because people got contaminated stem cell injections. So what happened was, at the time of harvest of these tissues, they got contaminated with E. coli and other bacteria. They've also found evidence of parasitic disease in some of these vials, sort of raising the question as to where these products came from, because they weren't diseases native to the United States. And so all that to say, we do not think these umbilical cord placental products should be used, especially in stem cell clinics that you might find just kind of in a strip mall area. They shouldn't really be used in the doctor's office. And if they are going to be administered, it should be under the supervision of the FDA. The FDA has to be overseeing the clinical trials associated with that. That's not the case for the others that we mentioned, platelets, bone marrow, adipose. But yeah, these direct to patient mailers advertising stem cells, we would advise patients steer clear of them and seek care with, start with their primary care physician, and then a local reputable orthopedic clinic.
So digging a little deeper back into PRP, those are still treatments that largely aren't covered by a lot of insurances. Can you speak to some of the evidence that might support them?
Yeah, absolutely. So for tennis elbow, there's really good data. So anytime there's kind of two levels of evidence that we think represents this really well. There's your randomized controlled trials where you have two patient groups, one getting PRP, one getting something else. And then you have your bigger attempt to synthesize that data called a meta-analysis. And I bring that up not to be too nerdy, but a meta-analysis helps you to account for any of the biases or the shortcomings in any of the studies. So back to answering your question, for the for tennis elbow, Ohio State was part of one of the largest trials looking at PRP for tennis elbow in over 200 patients, and showed that at 6 months, PRP was better than placebo. And we actually have gone away from steroid injections for tennis elbow because it does seem that like at a year, a cortisone injection at 1 year might actually make you worse just because of the negative effect on the tissue. For knee arthritis, PRP has been compared over and over to placebo, steroid, and lots of different formulations of the gel injections, the visco supplement. And in each one of them, except for one, platelets came out ahead. And so when you start running these meta-analyses to account for all the differences in platelet preparations and administration habits, it really doesn't matter how you slice it. PRP always came out ahead. And so we hope that insurers start taking this into account. I know that in select pockets, you will find insurers who are covering this. Usually I've seen it covered for tennis elbow. That seems to be the one that people get covered first, even before knee arthritis, even though we think the data for knee arthritis is more compelling.
That's interesting. So can you describe some of the studies that your group at The Ohio State University has been involved in?
Yeah, we've got our big one right now that we're the most excited about. We felt like the question of the superiority of PRP had been answered. So we wanted to know if the next generation, the ones we've already talked about, the bone marrow, the adipose, we wanted to know if one of those could beat PRP. If PRP works so well, and it's actually very easy to do. It doesn't take very much time. All things considered, it's not that expensive in comparison. And so for us, that was the gold standard. So we wanted to know, could something beat it? PRP had already been compared to bone marrow, and bone marrow did not beat PRP at 1 year. And so we thought that question was already answered. So we are studying and are getting very close to finishing PRP versus adipose. And so adipose is much more involved. We have to do a miniature liposuction in the office. And then we rinse that fat, we resize it through a filter so that we can inject it. And our it's not even really early data at this point. A lot of patients are meeting their 1 year out. So we're following patients for a year. Many patients have met their 6 month endpoint and some at 1 year. And right now there's no difference between PRP and adipose. And so I think one of our and I anticipate that will be the end of the study. I don't think adipose will beat PRP. So this is really good news because that means PRP works awesome. It's not that difficult for patients to get it done. They don't have to go get a liposuction done. And they're not missing out by not doing a bigger procedure. It just, PRP seems to work so well for knee arthritis. The part about this study that I'm the most excited about was what it's doing to the joint. So one question that always got brought up is, are we just treating pain or are we changing the disease process? And I kept hearing people say, well, we're just treating pain. And everything we know about platelets in the joint and what it does in a lab, I just kept saying to myself, there's no way we're only treating pain. This has to be making the environment better. And I don't know how. I don't think we're regrowing cartilage, but seeing our patients, we have to be doing something more than just treating pain. So as part of this study, patients were getting PET scans. PET scans are routinely used in cancer care. And what they do is the PET scan shows you metabolic activity. It shows you where tissue is metabolically active. And what we have found is that after PRP injections, after 6 months, where arthritis would be very metabolically active, the bone would be damaged and the skin would light up really bright. 6 months later, the intensity of that metabolic activity has decreased. And so that's what we're seeing, changes in bone metabolism. Now, this is preliminary. I can't make any definitive statements right now, but I think that is what is going to come about as our study starts to wrap up. I think that's what we're going to see, is that we're changing bony structure. And so that would change how we think about it, that maybe PRP could be disease modifying, that it could be slowing down the progression and improving the health of the joint, which no one has ever demonstrated that before. So I'm hopeful that's what we will show, because up till now, we have not had any intervention for osteoarthritis, that wear and tear arthritis. We have not had any intervention that changes the course of the disease. So compare this to the rheumatology world, where patients with rheumatoid arthritis, they used to be totally disabled and totally crippled by this disease. And then we got biologics like a Humira or whatever, and we can change that and we can stop that disease progression. For osteoarthritis, we never had that. And so that's important because more and more we're seeing all these young athletes who are 17, 18, 19 years old, they tear their ACL. Well, they're going to develop post-traumatic arthritis when they're in their 30s. And so we have to slow that down. And no matter what we used to be able to do, cortisone injections, gel injections, that never slowed it down. We hope that we are at the front end of demonstrating maybe for that patient, we can slow this thing down and delay the time to a joint replacement. So they're not having to get a joint replaced in their mid 40s. So that's the stuff that we're most excited about. Again, all preliminary, but the signal is very hopeful.
Well, that would be a huge step as far as coverage. If it's a fairly easy procedure, a fairly inexpensive procedure, and something that may not necessarily have to be repeated over and over and over in order to avoid a knee replacement.
Yeah, absolutely.
So you'd mentioned some of the stories that you're seeing about patients in clinic. Without sharing any patient identifying data, can you share a couple examples of what PRP has done for some patients that you've seen?
Yeah, I mean, there's two that like really stand out in my mind. One is a patient I just saw today, and again, it gets back to this question of, does PRP change the health of the joint? So this patient, they didn't have arthritis; they had what's called an osteochondral defect. So it's basically kind of like a hole through the end of the femur and the cartilage. So if arthritis, if I can use the analogy, if arthritis means that it's a gravel road where the whole surface is just uneven, that osteochondral defect, that's a pothole. So the whole road wasn't ruined. It was just that one little pothole. And this guy, he had said, I'm not interested in surgery. Can we just try some injections just to control my pain? We said, yeah, sure. So we've done it for several years now. And so knowing him for several years, I just repeated an x-ray because I said, well, it's been several years. Let's make sure things aren't getting worse. I was not anticipating anything other than, man, I hope this thing didn't get worse. We got the repeat x-ray, and that defect actually has filled in substantially. And I reviewed the x-rays with our surgeons who initially saw him. And they're not guys who would tolerate any BS. And because you're always wondering, well, did the x-ray get shot kind of funny? Is it just the angle of the x-ray? And all of us have looked at this x-ray and said, no, that thing is filling in. It is really changing. We are stimulating some kind of healing here. And obviously the symptoms are improving, but again, there's that signal that maybe we're changing the joint structure, which is just totally compelling, totally fascinating to me. And then the other is the person at the other end of the spectrum. So that's a young person with a focal problem. We also have a fair number of patients who are middle age or a little bit older, maybe in their 60s, still super active, and they have end-stage bone-on-bone arthritis. But these people are very active. They are still doing their snow skiing, they're jogging, they're going to their high-intensity group fitness classes, but their x-rays look terrible. And they come in and they say, I'm not interested in steroid because I don't want to damage my bone. And I had the gel injections and they stopped working. I'm too active to get a knee replacement. But a knee replacement is not going to make me more active. I just want something to help me with my pain. And when I say, yeah, well, we can try this, we never advertise it or promise it as we are not going to regenerate any in that bone-on-bone situation. We're not regenerating cartilage, but we move forward with it. And several of these patients have gotten profound pain relief that allows them to continue on in those activities despite how advanced their joint disease is. So that's really hopeful for me, because the trend that I've very clearly seen is that the patient's response is not based on the severity of their x-ray. It actually seems to be based on their level of activity. And so the higher the level of activity for the patient, that just tells me they're a very resilient individual and their body will respond positively to these interventions in many, many cases. And that's been a trend across the board. So if there's one plug for staying active, staying in shape, continuing to push forward, that's it. Because I think in my experience, that is the greatest clinical predictor of response. I don't know, maybe if you've seen the same phenomena in your rehab practice.
Well, I think that's really great that you brought that up, that, if you had seen this person's x-rays and not known them and just saw an x-ray on the screen, you might think, gosh, this person's in a walker or on a wheelchair, like 1 foot in the operating room.
Yep.
And to know that they're out snow skiing and doing active things like that, that x-rays and pain really don't have a super strong correlation. And you can definitely modify your physical outcome as well as your pain outcome by habits that you make in your daily life.
Yep, absolutely. Yeah. And so these are people who have maintained a healthy weight, a healthy lifestyle. They've altered some of their activities. And then, so I don't function as the foundation of their program. They're already healthy individuals. I'm just there as a little bit, in a supportive role. And so, and we've got great support from our orthopedic colleagues, both our sports knee surgeons and our joint replacement surgeons. We work together on this, and a lot of times they'll see somebody in that situation and they'll say, man, if you haven't tried PRP, you're so active, let's go try that before we commit you to a joint replacement, because we can't undo a joint replacement. And so it is really nice to have that relationship where you're really sharing the patient's care, no one's competing for their intervention to be superior.
Thank you so much for sharing all that information. If there are people who are interested listening to this and are interested in getting some more information, how would they find out more about your research, as well as, if there's someone listening in the Ohio area that is interested in finding out if PRP is right for them? How would they get in contact with you and your group at the university?
There are several easy ways. One is you can just Google my name, Mike Baria, Baria, in Ohio State Sports Medicine. That'll take you to my medical center profile, and patients can schedule online right there. It'll just say request an appointment, and you fill out a form and you can select your time in the office location. And then our office numbers are area code 614-293-3600. and 614-688-7160. And those are our main office numbers, and they can get in contact with us there as well.
Now, if there were one or two closing thoughts that you'd like someone listening to this podcast to remember, what would those be?
I think recognizing that number one would be, this field early on had a lot of promises to regenerate cartilage, and those things we just don't know just yet. We hope we're restoring joint health, but we don't know. And so we really are at the front end of finding out the really cool stuff about how to optimize PRP. So as time goes on, we're going to have more and more interesting and better treatments for patients. And then I think the second is what we talked about with that activity level. The stronger somebody is, the better in shape they are, the better they tend to perform, whether it's with me or whether it's after an ACL reconstruction or a joint replacement. These patients, the stronger you are going into a medical procedure, the better that procedure is going to work. And so whatever it is you have to do, if your injuries are preventing you from running, fine, you can't run, but maybe we can bike, or maybe we can walk vigorously, and maybe there's certain types of strength training we can do. And I do think that's maybe my 2B point is I think strength training gets neglected a lot. We see a lot of folks doing cardio, walking properly, and we absolutely love that. But folks tend not to get into the weights as much as we would like them to build up some muscle mass. And I think patients are surprised when they start doing that, how effective that can be.
Yeah, that's certainly something that we see a lot too.
Yeah.
Thank you so much for taking some time to spend with us, and it's been great catching up with you.
Yeah, my pleasure. Thanks, Dave.
That was a lot of fun catching up with Mike. I hope you got a lot out of it as well. I do want to reiterate that very last point that he made, that the healthier you are, the stronger you are, going into any surgery or any medical procedure will make you more likely to have a successful outcome on the back end. If you'd like to find out what you can do to get yourself healthier and help yourself either avoid surgery or recover faster from a surgery or from a PRP injection, please feel free to reach out. You can contact me at More for Life at 314-941-3970 or email me at dave@stlpainexpert.com. Thanks for listening. Hope you enjoyed the show. And if you did, subscribe to the podcast so you can get notified of our future episodes. Have a great day.
Thanks for listening to the St. Louis Pain Expert Podcast. We hope you've enjoyed the show. If you live in the St. Louis area and would like Dr. Candy's help to find a solution to your pain, visit our website at stlpainexpert.com. Email Dr. Candy at dave@stlpainexpert.com or call Dr. Candy's clinical practice at 314-941-3970. If you're listening from outside the St. Louis area but would still like some help, feel free to contact us to learn more about our virtual health coaching. Regardless of where you live, please share our podcast with anyone you know who would benefit from learning more about pain and what can be done to relieve it. And don't forget to subscribe to our podcast on iTunes, Google, Spotify, or your other favorite podcast platform so you get notified when we release a new episode. Thanks again for listening, and we hope you'll enjoy us again soon.